to the podium. Enrique, you are not going to present, so we will start the discussion. It's seemingly you are defending kind of different approaches to different kind of patients. So that's why I would like to ask those of you who are in favor of tendon transfer, when would you consider a SCR or a balloon, if ever? And I would like to ask those of you who are in favor of SCR or balloon to tell me when would you favor a tendon transfer and never do a balloon or a SCR? Short answers.
Yeah, so balloon in patients that are unwilling to have a tendon transfer because of the age or their activity, and they want not to go for a reverse. So this is the limited portion of patients that are the selected patient for balloon as first choice.
So I showed you the patient who has essentially no rotator cuff tear at all, and I did for lower trap, it covered the joint. So up till now, I have no indication in my hand, because lower trap is very easy for me right now to do. I'm not sure if things will change in the future, but up till now, I don't find difference, because with the graft, even without covering the joint being covered, so I think there's an indication for it if you don't do lower trap, but for me, I have no indication for it this now. It may change over time, I don't know.
So we are talking about massive cuff tears, but massive cuff tears are not the same clinical entity. So if I have a pseudoparalytic, a chronic pseudoparalytic patient, or an external rotation lag, I would not do I would do a transfer, because it's the only option. If you don't have a motor, you can't do anything. Except if you have an acute case, and in this case you can repair the graft, which is the best option. So if you, my indication for a balloon in pseudoparalytic is acute cases or acute on chronic cases that they had a good function before 2 months, for example, or 3 months, and then suddenly start having deterioration. And I want to take them back 3 months. And in this case, I would try to repair the cuff. I think it's the best option, and then put anything that would increase the probability of this repair to survive. And from this point of view, the easiest to do after a repair is to put an in-space balloon. The only thing that now I think is equally easy is to do superior capsule reconstruction with the biceps. The biceps is there. It's the same easily, technically the same easy. Happily, most of the patients that appear with a large or massive cuff tear are not pseudoparalytic patients, are patients that have mainly pain, and this pain produces limitation of motion. And in this case, if we do a medialized repair, a partial repair, complete repair, depending on what is the situation, the anatomic situation, then we can put an in-space balloon and have a very good clinical result, because we are going to stop pain, and stopping pain and distributing better the forces and bringing the head to a better maybe position, we are going to have easier rehabilitation and then a better function of the remaining calf. What calf remains after 3 or 4 months after our repair.
Okay, actually in Japan the balloon is not available, but even the balloon is available in Japan, but maybe I don't use the balloon because maybe the indication balloon and the SCR is the overlap, and maybe the SCR can cover all of the indication balloon, so that's why maybe I don't do the balloon. So, but and indication will show any type of irreparable cuff tear, as I told you, my slide. Maybe we can cover all of the irreparable cuff tear, and tendon transfer alone. Actually, long time ago I did tendon transfer, but now I stopped. But recently now I'm starting to think about the SCR plus tendon transfer for some cases, but still just thinking.
Let me ask you this. So I know SCR work, like, and we. So in your presentation, 80% of the MRI you showed, you have proximal migration still. They're not centered. So to talk about SCR centering the shoulder, it's not. Not in every patient, at least, just follow me, okay? So it's not, but it's relieving pain and you have long-term outcome. And you look at the MRI at 2 years, 4 years, it's still high, it's intact graft, and the patient's still doing very well. That's number one. In the ASS this year, they presented this series, they have 80% failure rate of the graft on MRI, and the patient's still doing well. And they were wondering, even if you have to fix both sides of the graft, because they think the graft itself, just because it's interposed, it's causing less pain. And the third point is, in patients with fractures, if you look at their images, they have almost subluxation whenever the joint, the capsule is ruptured, because they have like there's this decompression effect. So I wonder whether the sealing effect, number one, and the interposition effect is number two, is what's causing the good outcome, based on what the American have showed in the ASAS and what you have been shown in your MRI. What do you think?
First question, I forgot. First question.
The first question is, even though it's showing in your MRI, showing the head still.
Oh, yeah. Actually, yeah. Yeah, even the super migrated a little bit, but in the stabilized the human head, in them the deltoid works very well. So, for example, even the conservative non-operative treatment and the super migrated, but some patients they can elevate arm because in that case the acromion the stabilized human head. Then it's not many patients, but some patients can elevate arm, and even the patient has the irreparable cartilage. So the position centering the human head is not so important. Actually, the stabilize the human head, the most important part. And the second question, the retail cases, right? Retail cases, in my experience, of course, the same thing. Even the graft there, but the patient pain still pain relief. Actually, but function is not so excellent because in my case, all of the graft is failed in the lateral side. Then MRI shows what's happening in the graft. Graft is actually attached to the acromion. So the graft is attached to the acromion to the glenoid. So like like a hip joint. So that's why the normal impingement, the graft was torn, but actually the covers under the acromion, so that's why the pain relief. But still human head migrated because the graft cannot stabilize glenoid joint. So that's why the function is less. And the final is what is that? Okay.
Bassem, we have 3 questions in the room. Please, Fair.
Yeah, I have a question for the balloon technique. So how likely is it to have a reduction of range of motion because of lack of subacromial space because of the balloon? I don't know. I have not heard about that. So are we seeing problems like this, reduction of force that results also to functional problems in strength and everything like that?
So your question and the question you gave to Dr. Mihata is more relevant also to the balloon because the balloon is absorbed. So we know that if he centralizes, if he keeps the head down, it does this for a limited time. So how it happens that the patients with a balloon implanted 2 years before or 3 years before are still have a good function? There is no balloon there. Okay. And probably the answer is that when we, what we want to do is to pass from a painful situation to a non-painful situation, and to make a non-compensated, compensated function. And this probably does the balloon. It gives a period that allows rehabilitation, and this means allows everything that works to work better, everything that is still function to function better. And this is the result that we obtain, and these results remain after that.
So the balloon more or less functions like a meniscoid, you mean that?
No debate, no, sorry, no debate.
Okay.
We are out of time. Ofer is next.
So I think all of you are correct. And we showed many years ago, 15 years ago, with a study on the deltoid rehabilitation regime, you don't need to do anything, just do a deltoid regime, and in majority of patients, they will do fine. Some of them will fail. Those who will fail, we need to do something else, a reverse shoulder or something like that. So I think all the techniques, beside the tendon transfer that obviously you bring a motor, but all the other techniques, the balloon, this superior capsular contraction, what you do, you allow the deltoid to rehab. Once you rehab the deltoid and the function of the deltoid, then the shoulder learns how to do it correctly, then it remains, even if you have superior migration.
I read your paper, 2008, I mean, it was a 9 months rehab. So would this...
No. It was 6 weeks rehab. The patient did 6 weeks exercises. When they came back after 6 weeks, they could do that. They carried on. We told them to carry on to do the exercise forever. But after 6 weeks, there was improvement. 6 weeks.
I have a question for Dr. Miyata. Thank you, very nice, because you continue to analyze your theory, and for us it's very important to understand. Because I give you a case, a clinical case. You see a patient with a lag sign of external rotation, or boner sign. You do X-rays, there is a superior migration of the humeral head. You do MRI, there is a complete atrophy of the supra, infra, and teres minor. On my question, a very nice subscapularis. My question is, you do a superior capsular reconstruction, but I don't understand how to restore active external rotation because you have no muscle in external rotation position 1. You have no muscle. How it's possible to restore active external rotation?
Okay. Yeah, that's a very nice question. For the actually name is SCR, but actually superior posterior reconstruction is possible. Anterior side may be impossible, but even the infraspinous tendon tear, the teres minor tear also. In that case, actually the home blower sign positive, before surgery external rotation lag sign positive, but actually the more than 80% it's recovered just after SCR, but still very weak of the external rotation strength, but they can stop this position, and very slowly they can reach the back head. So not so excellent, but maybe if we add the tendon transfer, maybe the much better function for this patient. But just SCR, it's the recover the external rotation lag sign, but it's not completely partially.
So I have now a group maybe of 14 patients who have failed SCR, mostly for ER. So mostly for ER, and I did for them lower trapezius. So I think this is very, very valid point, and this is a very valid point for the audience as well. I think when you have no ER and teres minor and infraspinatus are gone, you need motor to get external rotation, especially if the patient complaint is external rotation. Okay. Yes.
Yeah. So okay.
I just want, Dr. Ellison, those failed SCRs you operated on, they were SCRs with which graft?
United States, so you know the answer.
But I think it's an important question. You have SCR with fascia lata, you have SCR with human dermal allograft, you have SCR with xenograft. Yeah. I know we have lots of variables in the techniques, but I think it's important.
No, Carla, I'll tell you. No, this is all with the dermal graft, but I'm going to tell you, they came to you. Let's say one of them came to you, or some of them came to you. They have ER. They tell you, I'm okay here. I have not much pain, but I have no ER. And you get the MRI, they have infra and teres minor fatty atrophy complete. What would you say?
I never did an SCR on such a patient.
That's beautiful. That's perfect. That's what I want to hear. That's it. Yeah, I got my phone. This is it. I mean it. This is very important for the audience.
Another question in the room?
Yes, I have a question. All of you show excellent clinical outcomes, but what regards the strength? So who of you can say to your patient, you will have, we can say, a good strength after the operation, or no of you can say this to your patient?
I avoid to do a balloon if we have a patient that is complaining mainly of loss of strength, because it's the best way to have a dissatisfied patient after the operation. So it's an exclusion criterion. We did it in the beginning, stopped doing it because we have dissatisfied patients. We do a balloon when we have patients that are complaining for pain, and they may have loss of external rotation, but not an external rotation lag, a painless external rotation lag. They cannot external rotate, because they are painful. And except one indication, if it's acute, if it's an acute tear and you have a good MRI and you have good muscles and you have external rotation loss, then I would like to take this patient to the operating theater as fast as possible in order to repair the cuff. Because I think that it is the best option. You are going to have the best clinical result if you manage to repair the cuff.
Thank you. So about the strength, I can say you that latissimus dorsi tendon transfer does not give back the same strength of the native calf. And this is the lat dorsi has not, the muscle belly is not as large as the posterior calf that has to replace. So when you have manual workers, they ask you for giving back the ability to have strength and resistance. You have to tell them that you can give them some more ability but not recover what they lost years ago.
Along the same line, I usually tell the patient around 80% they can get external rotation strengths, but the flexion is unpredictable. I tell them the pain, more than 90% will go away. 80% you'll get external rotation strength. This is going to be stronger. But the flexion, it varies between patients. Some of them they have it, some of them not. And talking about anatomy, because some patient, depending on the body, everyone else, deltoid strength, scapula, everything else, all of this take into consideration. I will not promise some flexion strengths. I can promise some more external rotation strengths.
And one that is predicting for unfavorable outcome is when the patient has some kyphosis, and that is, you can predict the outcome is not that good.
Yes, Dr. Mihata, yes.
So after HR, we can expect the improvement of shoulder strength. Actually, another study showed the abduction strength, maybe 2 years after surgery, compared with the contralateral side, average number around 80%. And the external rotation strength also the 70 to 80%, and internal rotation also 70 to 80%. But we measure abduction strength in the outside. In that case, 80%. But the abducted position still the weak. Actually, 60% of the contralateral side. But anyway, the muscle strength, compared with before surgery, they're much higher than before surgery. Actually.
Thank you. Yes, a question, maybe.
I would like to add something to the previous question about muscle strength. I think we should modify a little bit the question in terms of, is the strength of the patient post-op better and the functionality better than what they were before? Because maybe we cannot obtain 100% functionality, but I think the main idea is they get better after operation than before. So is it something, let's say, guaranteed?
There are two questions. The first question is from where you start, and the second, what is the clinical condition preoperatively? And the second question is this going to be normal at the end? So I don't think that we can have a normal patient, and the condition that we start, it's very important for the decision. If you have a pseudo-paralytic with a little pain and an external rotation loss, then try to do something that is going to give power. If you have pain, then try to do something that stops the pain, because if the patient is not painful, it's going to gain power. It's going to function better and then gain power by what he has, and he is not working at the present.
Okay, thank you. We have one more question. Just one question for Dr. Mihata from me. Thank you for your presentation, and you saw a very nice rate of healing of your SCR. But on your slide, maybe I made a mistake, but I only see T1. And T1 is very good for the fat infiltration. Mm-hmm. But if you want to analyze the healing of a tendon, T2 fat sat is better. So do you have an example of T2 fat sat MRI to show us very good healing of your tendon?
So T2 fat sat, yeah, we have T2 fat sat also, but actually fat saturation MRI does not show the fatty infiltration. It's because of fat saturation. So that's why I usually check the regular T2, and also of course T1, T2, everything we check. Okay. Yeah.
Thank you very much. I think we are agreeing to close the session. Thank you.